Hello, welcome to everyone. So today I'll be hosting Dr. Sunil Menon. Welcome, Dr. Sunil Menon, on the low carb in a rural setting. Dr. Sunil Menon is a MD in respiratory medicine from University of Mumbai. He has completed certification courses in functional medicine and therapeutic food plans, a component of personalized nutrition. Presently, he is working as honorary consultant physician and head of lifestyle clinic at Sri Satya Sai General Hospital, Puttaparthi, Andhra Pradesh. He developed interest in low carb diets in 2017 and introduced this approach to the doctors and physicians working at the Sri Satya Sai General Hospital, and has conducted several meetings, workshops, and low carb conference at the hospital. So, along with support from the medical superintendent, has established a lifestyle and nutrition clinic with the assistance of 2 nutrition trained dietitians, and is now head of the lifestyle clinic and manages various diseases of patients, including metabolic syndrome, diabetes, obesity, and PCOS. Now, I'd like to welcome Dr. Sunil Menon. Hello, doctor.
Hello, Venkatesh. Thank you for this lovely introduction. I'm extremely proud to be here to sort of contribute a little bit of findings I've had and the experiences I've had practicing low carb.
So my first question is basically, how did you come across low carb? See, basically you are a MD in respiratory medicine, and then you are there in UK as well as in Dubai.
Yeah.
So how is it that you came into low carb? So can you tell me briefly about your story on low carb?
Well, what happened was I was basically interested in food and nutrition, which is not taught in the medical college at all. When I took the respiratory medicine disease, I was interested in asthma and allergy. And that took me on to looking into food allergies. And I found some extremely good books, which led me to this group called Clinical Ecology and Environmental Medicine group in the States. So when I was in Dubai, I could get over there and get trained in this subject. And they were very nutritionally oriented, and they were diet oriented too. And they did a lot of work on food allergies. So this put me onto the track of realizing that food and nutrition is important, but nobody's talking about it and nobody is really doing anything about it. And when I did the certification courses in functional medicine, they also had this food aspects and therapeutic food aspects. And that led me on to research into all interesting books in nutrition and food, which brought me into books on low carb. And I found that this is a field which nobody is talking about either. Very much. Lucky enough, Professor Noakes came into the picture, and Dr. Jason Fung came into the picture, and Professor Bickman came into the picture. And after I read all that up, I suddenly realized this has to be applied in my setup, which was a mainstream hospital. So I had a lot of workshops done, and most of my doctors were so supportive that it came to the point when we got a new medical superintendent who sort of resolved his own problems following a diet schedule, which I didn't know about. He told me later. And he was impressed, and he went into understanding insulin resistance is very important. Chronic disease is very important. And that led to the fact that he said, okay, start a department. I think this is the first hospital that is officially, mainstream hospital is officially having a lifestyle department dedicated to putting the low carb. And I got a dietitian who's actually joined DLAB.
Okay, that is good. So now, can you give us a brief about your setting there at the hospital and how are you going about with low carb?
Yeah, I can go into the slides.
Okay.
Maybe with the slide. Right. So the first thing that happens in any aspect of a patient is you must know where the patient is living and where the patient is coming from. And if you see Puttaparthi there in the map, this is the district we look after, and there are about 96 villages. And the most distant village we actually treat is 140 kilometers away. So they have to come all the way to the hospital. But lucky enough, we also got mobile hospital, which is the first of the kind in India. And my
Okay.
superintendent actually runs that. He's got two hats. One is he's the director of the mobile hospital, and he's also superintendent of my hospital. So he
Okay.
gives, and he knows the statistics of the problem. And what we realized is, we look at the years with diabetes, you'll find that patients who are diagnosed within 1 year, small number, and that number is increasing. And patients who are diagnosed within 5 years, that number is the highest. Patient who have got more than 5 to 10 years is also very comparable to the 1 year category. This is important because if you can reverse diabetes if you diagnose it within 1 year. 90% of them can reverse on a low carb diet. And unfortunately, patients don't come that early to us, and that's what's happening to the villages there. They don't come to the hospital unless they're very ill. The 5-year population, 75% can reverse. The other statistics is that the 30 to 40-year-old numbers are now dramatically increasing, and we are very worried about that because nothing much can be done, and we don't know what is happening in the villages compared to the other years. So these are the two aspects of kind of patients that come. And most of the patients that come to us are the TOFI type. And the TOFI type is the typical thin patient with a pot belly, with all the visceral fat. And invariably, that is the type of patient a lot of other speakers have talked about. Southeast Asians are like that. We have the other problem that our ectopic fat deposition is much more in the liver and muscle because we don't have subcutaneous fat at all. And we also have impaired insulin secretion. And because of the lean muscle mass, all these things contribute to the fact that we become diabetic very quickly. And the other issue is when you're pre-diabetic, which normally is not easily diagnosed unless you go for the HbA1c test, we go into the diabetes state very quickly. So I've seen within 5 or 6 or 7 years average, they become diabetic. Because all these problems are happening in the villages, the question is, what do we do for them? Especially when...
First of all, doctor, see, basically what people are telling is the chronic diseases basically because of the affluent society. So over the year, rural poor also getting this diabetes and these
So that
other
is why
chronic diseases.
the genetics, Southeast Asians, whether they are living in a rich place or a poor place, these Southeast Asians, if you load them with carb, then they go through the same route. So we have to see what to do. So when we looked at the people there, according to their culture and their religion and their practices and all that, we had other problems with suggesting any other form of diet than vegetarian. And our in-hospital patients and our dietary sections are supplying inpatients, we have to stick to a vegetarian meal. So our focus has been, to sort of find a vegetarian meal which satisfies things. The problem with this is that most of our patients are malnourished and they are also protein deficient. So we have to juggle a lot of balls in the air to really find out which will fit. What is a good thali that can be made for these people? And we have reached some sort of compromise thali, which if we get time, we can talk about. But the main importance is to bring the patient on board, because these patients are accustomed to collecting drugs and eating drugs. So when we set the lifestyle clinic, the first thing we did was we found education very important. And as you see that I spend a lot of time, and we give only appointments and see these patients, we give them at least 40 minutes or 45 minutes to explain the condition, explain the diet. And I got the Dr. Anwin's infographics and charts on the wall, which are all in English, but I translate them to the patient's convenience. And surprisingly, the patients actually listen very carefully when they are told that, your blood sugar levels and other issues can reverse and can be better controlled if the diet changes. It's only then, after the education bit, the next step we do is we get the family involved, because the cook of the family is most important. So we found counseling the patient and educating them is not enough. The family has to become supportive. So we get the family involved, and then the dietitian comes in to give them the menu that they can follow, depending on what their cultural background is, and what their economics are, and what they can afford. So where we really succeeded was by introducing the glucometer. So initially we thought, we'll give them the glucometers, but we found that many of them were getting spoiled and they were not returning it and not taking care. So then we found many of them were ready to buy because most of them had smartphones, and 500 rupees was not an issue. And Modi has introduced a cheap version of this. It works. So what my patients do is we tell them to reduce the carbs as much as possible, but they argue and say that they want to try this and that. So this chart is an example from a patient who was told to keep a 2-hour glucometer readings for about 5 days, and you'll find that in the chart it is obvious that whenever they eat paneer and egg, she was a lady, and you find the sugars actually dramatically dropped. And when she actually ate ragi, it actually gone up to 230. Most of the carb-based foods, also chapati and dosa and idli and all these things, increase the sugars. So it is very evident to her that eating paneer and egg was the choice. Along with this, of course, she was allowed vegetables and yogurt, things which I didn't put in detail. This is the kind of results we achieved. This is achieved in, between, I think, 2017 or 18. And in this, all of them are within 1 year. They're newly diagnosed. And if you look at the HbA1c, we got various high ranges. And many of them actually came down and reversed the diabetes. And this is a quarterly follow-up. And the fourth patient actually was a 10-year-old diabetic. She had diabetes for 10 years. And even that patient, the HbA1c came down to 6.6.
What is the typical diet and the amount of carbohydrates in these?
Yeah. There was a slide which I put up in the earlier this thing, but that is missing in this particular talk, because that actually showed the formula. And in that formula, we actually replaced the traditional millets, and we found that ragi doesn't work, but there are other millets called the Sridhanya millets, which they locally make. Most of the farmers, they grow it, but they don't eat it. They have switched to rice and wheat. So we found that by giving a small quantity of that sort of satisfies the psychological aspect of eating that. But we insist on eating paneer. For the vegetarians, paneer is the alternative. And soya is the other alternative, which we mix with chana to make a roti. So we found that the breakfast, lunch, dinner, if you measure it properly, and we show them in measurements and not ask them to weigh and all that, the villagers can't understand that. It comes to about 120 carbs, 120 grams carb. And they can split it any way they want. We don't call it breakfast, lunch, dinner. We say that you cook and you eat it twice a day or thrice a day, but you can't eat anything more or cook anything more. So we are trying that our inpatient patients also. So we'll have the results only after about 6 months to a year.
But doctor, millets millets have the same carbohydrate content as any of the other greens, isn't it?
Yeah, you're absolutely right. So that is why the discussion always goes into the numbers. But I had an interesting paper to show you, which shows that individually the food that finally is digested, the same food in the same person, the glycemic index doesn't matter. You'll find that the sugar levels will change dramatically from one day being slightly high, one day being normal, and one day being very high. It all depends on the activity. Then the same food given to two different individuals will give different glucose responses. So the numbers don't actually match in the patient. So that is why the glucometer is important. So the story that somebody will eat millet is the same glycemic index as rice, that has been sort of misunderstood in many ways, because they haven't understood that the individual, the way they handle carbohydrate, it differs from patient to patient, which is why we need the charting with the glucometer. So then we know their carbohydrate threshold, and that is very, very important. They have a fat threshold and a carb threshold which varies. So we have to make them eat the food and see, because if you remove millets out of their diet,
we were thinking that actually soaking and then maybe
no, we are doing it the traditional way. Traditional way, yeah. Not the powdered millet. Traditional way, 8 hours soaking, and the amount the millet is very filling. So and we always add the mix we suggest is more vegetables and always paneer.
And a small quantity of millet.
The quantity of millet is depending on the glucometer readings, because the
Okay.
quantity we don't fix. So we say that, okay, we start with one quantity.
Okay.
And if the glucometer readings are fine, that means you are okay with it. You know?
Okay.
So that makes more sense to the villager.
Okay.
So they keep coming every 5 or 6 days for us to analyze their chart, and they do it very sincerely. I thought that, they got children who are very educated,
Okay.
and they are the ones who translate and do the blood test for us and write down the chart for us.
Mm-hmm.
And lucky the next generation, all of them are pretty well educated, and they have children in the 10th standard and college going and all that. And we that's why we involve the whole family in this.
Okay. Okay.
Yeah, otherwise it
What about
doesn't.
fats, doctor? What are they taking?
Ghee, we asked them to switch to ghee or coconut oil. That's the easily available thing here.
Okay.
But we found that a little bit of cold pressed peanut oil doesn't make much of a difference.
Okay.
So they can't afford, they can't eat something, and
Yes.
so we go with the fact that we have to work on this, and the data of what is happening to each individual asset we are looking into.
Mm-hmm.
I'm only showing the HbA1c results
Mm-hmm.
to show that a vegetarian low carb diet can work. All these patients are entirely on vegetarian diets. There are no eggs
Okay.
in there. There are no other things in there. So that is feasible. It's not that vegetarians can't do a low carb. It's a question of
Basically, you have reduced the carbohydrates around 100 grams, 100 to
that's right.
120.
That's we found by a rough calculations. That's what because we are not doing the scientific method. But once my
Uh-huh.
dietitians come into the play, and the dietary
Mm-hmm.
department is serious about this, so they are doing all the calculations. So maybe
Mm-hmm.
in the next 6 months' time,
Mm-hmm.
I'll have it worked out
Okay.
exactly what.
Okay.
But roughly, we use the chronometer web app
Mm-hmm.
to count the macronutrients.
Okay.
And that web app is very good. You just put the food in, put the quantity in, and we have found that the breakfast, lunch, dinner we formulate comes to about 100 grams, 120 grams actually.
Okay. Okay. Now, what are the myths of nutrition the rural people have, doctor?
Yeah, the nutritional issue, though, the main thing is the protein, and surprisingly, they're all B12 deficient.
Okay.
And the other thing is vitamin D.
Okay.
And the other fact we realize is most of them are not iron deficient.
Okay.
And this
Why?
is something which comes up every time. They say that, okay, you're saying this patient is malnourished, but the
Mm-hmm.
hemoglobin is always 12, 12.5, 13, around that
Mm-hmm.
range. When we would expect them to be, below 10 or 9 or whatever it is. There are some people, of course, who are very low,
Mm-hmm.
that we can correct. But they need supplementation, and we look into B12 and vitamin D.
Mm-hmm.
The problem I'm having is to give magnesium with it, which is
Mm-hmm.
recommended. And they're
Okay.
vegetarian, so vitamin K is also not
Mm-hmm.
really okay too.
Okay. Okay.
Um, that's another bit of the diet. So the diet, the dietitians are very, very seriously, breaking their heads to find where to
Mm-hmm.
get the ideal diet, and it doesn't
Okay.
exist. I mean,
Mm-hmm.
you can't find any resource which says that this is the ideal thali
Mm-hmm.
for a vegetarian. So they're telling them either you add eggs or you
Okay.
eat non-vegetarian food, which like I said, culturally and other aspects are there, and they refuse to do that.
Okay, doctor, you have any unique case that you would like to share with us?
Yeah, what I would like to do is in a recent case that came up, just to show the effect of diet on a very badly controlled patient. So she is a case of Lada. She's a married case. She had one full-term delivery, and
Mm-hmm.
at the second delivery they had to abort the baby because at that time she was diagnosed with,
Okay.
insulin-dependent diabetic. And if you look at her, you'll she's malnourished, and you can see sarcopenia evidently there.
Okay.
And she was put on this sort of standard dose of 15, 15, and 10 units of rapidly acting insulin, with an
Mm-hmm.
addition of 10 units of the NPH insulin, with some B complex, vitamin C and vitamin
Mm-hmm.
D. And her HbA1c is, when she came to us, referred to
Mm-hmm.
us, was 13.9. And
Okay.
she's been uncontrolled right from 2015. And if you look at the HbA1c chart, you'll find
Mm-hmm.
right from the beginning 11.5, 12.7, 14.7, 15.7. And
Mm-hmm.
when she came to us, she was 13. So this indicated that, her insulin really, the requirements were not being met, and she was on a high carb diet. She couldn't afford insulin. So she would buy some and then use some for 10 days and then stop using it.
Okay.
So we had to then arrange some insulin for her from the hospital, and she said she agreed to buy, the NPH insulin, and the other insulin we arranged. But even then, the diet was the issue. So she was an auto driver's wife, and we had a lot of chats before we changed to eggs, and they agreed to take eggs. And I said that, can you take eggs, 3 times a day, or at least 2 times a day? And the afternoon you do eat our kind of mix of millets with paneer and vegetables. And we gave her a glucometer and told her to keep the chart. And when she came back, this is her result. The 300 on top was the averaging of a result before the low carb. And you find that after the low carb, it is the PM and AM, before food and after food, blue and red lines. And you find that it's all patterned out into within 140, and somewhere along even she's been to of the removing the carbs. The issue is that we'll have to see how sustainable this is.
Correct.
And that is where we have to follow her up. And like I said, this is all very new to the villagers here.
Okay.
And it's become a big kind of talk in the campus, in the villages, that this new doctor has come who's making us, do crazy things with diet.
Okay.
And inevitably, I think that's a good thing, because people are realizing that people are getting better.
But then you must be spending a lot of time with the patients, isn't it?
That is why we have that special days, 2 days a week for them, and only with appointments. And we, like I said, spend 45 minutes.
Okay.
That's the first consultation. Consultation. Then the dietitian takes over.
Okay.
And she's there available every day. We do all the measurements, and then we check the charts only once a week. And everybody's on a chart. So that if they cheat, we can know immediately.
Any other cases which you would like to share, doctor?
Yeah, the one case which I would like to share, which was perhaps my first case in 2016. And this particular case, the main thing you must see in this big report which I picked up is that she was a cardiac patient, been seen regularly in the cardiology part of the hospital. That is, the super specialty hospital is part of our setup, and we are a sister concern, the general hospital. That's in a separate campus, and that's why all the big departments are there. And the cardiac department was seeing her because she's settled here. But her story is pretty unique, because basically her story starts from coming to Parthi in 2008. And at that time, she was seen in the cardiac OPD in the super specialty hospital. The BP was 210, 110. She was diagnosed to be hypertensive, and she gave an old history of a myocardial infarction in 1999 or something. So the papers and the reports only show the evidence of old MI and hypertension and high BP, for which medicines were started. And she followed up only there. She didn't follow with us, because they had a physician then. Now they don't. And this went on for a long time. And suddenly in 2011, the diagnosis of diabetes is crept in. And they've started metformin on her. And then her left ventricular ejection fraction, which here, if you see, is 20%.
Okay.
And that was much later. But her ejection fraction then was 50%. And if you see that after she came to us and we put her on the low carb diet, her ejection fraction actually came back to normal, 45 to 50%. And this was in 2018, because by 2016, she had deteriorated to get this level. So from 2008, they were treating her with blood pressure medications, and they were ignoring the diabetes part.
Okay.
Which went on, increasing to a level where when we saw her in 2016, she was in a bad shape. She came like this to us.
Okay.
And then we put her on insulin. because her HbA1c then was 14.4.
Okay.
But unfortunately, she refused insulin and we had a lot of problems with that. Being a Russian lady, didn't know what to do. And she was not getting properly controlled. And she couldn't walk around. She could just go to the bathroom and come back. So as a last resort, on one follow-up, somewhere in March 2018, I suggested that why don't you go on this low-carb idea? And at that time, I was just sort of putting the knowledge I had without any guidance. And in her case, she was eating a lot of processed food and noodles and sugar and other things. So we removed that out and she was ready again to eat eggs. And then she made her own Russian preparations I don't know about. And when she came back for follow-up, after 3 months, she had improved quite a lot. And then after 6 months, she disappeared again. And then when she came back again for a follow-up, to insist she come back, she was practically normal. So this was very surprising. And so I sent her for a repeat echo.
Okay.
And the repeat echo is showing that the ejection fraction has come back to 45 to 50%.
Okay.
And she maintained this. I saw her about 3 months ago before she left for Russia. Now she left for Russia 3 months ago. And this reversal at that time I didn't expect. And now I got 3 patients who are doing similar fashion. They're switching their ejection fraction and heart function. Whenever they cheat and go off the diet, I find that the heart function deteriorates, the BP goes up, and the HbA1c goes up. And these people don't keep the regularity of it. And then they come back in a bad state again. And then we put them back on some sort of carb restriction. See, we call it low carb, but what we are doing is only some sort of carb restriction. And this particular lady, the lowest she reached was 7. HbA1c 7. We couldn't lower it any further. But with that 7, her ejection fraction came back to 45 to 50%. And her activity of daily living, as we call it, a person who couldn't go to the bathroom, was going shopping around Puttaparthi.
Okay.
And now she visits the hospital, using a walker because she's got a lot of sarcopenia.
Okay.
Which got worse because I'm sure her protein intake is still not adequate. So that is only a factor. Otherwise, a person who's coming on a wheelchair started walking and shopping. So for me, that was in my file for a very long time. And when I realized that the low carb can work so well, even when roughly and given with a vegetarian background, adding only eggs to the diet, and removing the processed foods. And the HbA1c we could reduce only till 7, and even then the results.
Okay, doctor. I think we are coming to the end of the session.
Oh, thank you very much.
We are really thankful that you have come and given us a beautiful lecture on the rural setting of low carb and how are you doing. Basically, it is one of the toughest jobs to take up a rural setting and do low carb. So that is what my thinking is. Now I'd like Shashikant to say a few words.
Dr. Sunil Menon, thank you for joining. And your perspective of applying low carb in rural setting is very important. Even though you must have used some carbohydrates like millets, nevertheless, it becomes a ray of hope for people, even in a rural setting, to get some benefits out of, or a lot of benefits out of low carb. And I think your session is very, very invaluable. I want to thank you personally for accepting and coming in this session, this historic first of all event, and sharing your knowledge.
Oh, it's an honor. It was an honor to be in your D-Life field. And I look forward to further sessions and interesting sessions.
So we will have a little more extensive sessions with you because your insights in rural setting is very, very important for India.
What I would like to add is the dietary department of the super hospital has agreed to put low carb into their menu.
Great.
And we'll get the results in about 6 months.
Great. Thanks.
In fact, the menu at present is high carb.
Yeah.
Okay.
And we know that, and the doctors are complaining that the patients are eating the diet, and the sugars are jumping around. So we are the dietitians have come on board. I'm lucky to have a set of physicians and doctors who are supporting me and referring cases, and they are diagnosing metabolic syndrome and early diabetes and pre-diabetes. So they know what metabolic syndrome is. They know what a pot belly is. The moment they see a patient with pot belly, they immediately put him under her under the measurements. So
Thank you,
I think
thanks.
Okay,
Doctor.
okay. Thank you,
Very,
doctor.
very
Thank you.
valuable
Thank
insight.
you very much for coming.
Venkatesh sir, thank you for hosting it very nicely.
and thank you, Venkatesh. Thank you.
Doctor, I'll
Thank you,
send
sir.
message again that we will have a very big extension session. So thank you very much.
Thank you,
Thank you, sir.
Deelas.